I have the distinct pleasure of introducing a friend and colleague, Dr. Srinath Adusumalli, who's an assistant professor of clinical medicine at the Perelman School of Medicine at the University of Pennsylvania. He's assistant chief medical information officer there, as a general cardiologist, echocardiographer, assistant cardiovascular disease fellowship program director within the Division of Cardiovascular Medicine, and also serves as the clinical innovation manager for the Nudge unit and the acceleration lab at Penn Medicine for healthcare innovation, which is a really cool group there. And I think much of his talk may be relating to a lot of the work he does with the Nudge unit there. Obviously, Srinath is quite busy just based upon all the work and leadership roles that he holds there. And I really appreciate you taking the time to speak with us here. We're a consortium of cardiac rehab focused individuals throughout the state of Michigan from multiple different sites, trying to kind of bridge the gap that I think you're going to nicely highlight and potentially offer some solutions on how you guys are approaching the problem. Please go ahead.
Thanks so much, Devraj, and really a great pleasure and honor to be with you all today. Certainly kindred spirits, sharing our passion for cardiac rehabilitation. So glad to tell you a little bit about how we've been working in the space, at least at Penn Medicine. It's my two disclosures, just two unpaid roles on the advisory boards, unrelated to this talk here. And so this talk is framed around, as Devraj mentioned, at Penn, we've launched, at least at the time back in 2016, that fairly unique group, which was aimed to think about how we apply principles of behavioral science and behavioral economics into the context of a healthcare delivery system. So how do we design systems to produce human behavior and outcomes based on that behavior that we desire? And long story short, actually, cardiac rehab referral was one of the first problems that the Penn Medicine Nudge Unit took on. It's actually how I got involved with the Nudge Unit, and have since been working on a couple of projects in this space that also incorporate principles of behavioral science. So I'll tell you a little bit about sort of nudging and behavioral science first, and then talk about how we think that the principles have application to cardiac rehabilitation, both from a clinician referral perspective, as well as from a patient attendance perspective. So I think for most of us, it might be fairly intuitive that human behavior is the final common therapeutic pathway, no matter if you're working with a medication, a vaccine, a targeted therapy. Ultimately, the outcome, or producing the outcome that one desires from providing that therapy, is dependent on human behavior, and oftentimes relationships between clinicians and patients. And we know in many cases that our decision-making, medical decision-making, both on the part of patients and providers, is often suboptimal. Sometimes we provide too much care, and we know that in the sense of nearly 1/3 of healthcare spending being wasteful and potentially unnecessary. And then sometimes we fail to deliver evidence-based, equitable, guideline-directed care. And that's been demonstrated in many specialties. I think certainly a large evidence base in cardiovascular medicine as well. And so with the advent of electronic health records and implementation of electronic health records, as well as other digital modalities and channels in which we deliver care and interact, they all provide, we think, opportunities or levers to be able to intentionally design choice environments to produce behaviors and outcomes that we'd like to produce, that are aligned with our patients' health. So we know lots of I don't necessarily have to tell this group, and some of this work is produced from here. And I know, Devraj, you've done some great work in the space of around referral to cardiac rehabilitation, gaps in referral, certainly gaps in attendance, and the implementation gap, or the implementation problem around cardiac rehabilitation is, I think, quite apparent to those of us here. And also why we thought that this would be an interesting target for a nudge or a behavioral science-based approach. So simultaneous with all this, we know the science of motivating individuals, both patients and providers, has evolved. I think previously we used to think maybe it was just enough to provide information and say something was bad or good, or conversely good to do. Then we started experimenting with principles of standard economics, where we would believe that humans act rationally and act to maximize value. So perhaps providing rewards, maybe even financial incentives, might be enough to produce the behavior change we intend to produce. And more recently, our groups and now several others have started to explore concepts of behavioral economics, which use the understanding that human beings act irrationally, but in predictable ways, and that we suffer from common decision errors and use common heuristics. And so the focus here really is on empathetic, human-centered design. And so that leads me to the concept of nudging. And what a nudge is a change in the way choices are presented or information's framed that ideally would alter someone's behavior in a predictable way, but ultimately doesn't restrict the choice. So individuals still have the freedom to make choices, but what we're trying to do is study methods in order to of predictably changing behavior without restricting that choice. And ultimately, nudges should be transparent, shouldn't be misleading, easy to opt out of if needed, and then also aligned with the welfare of the person being nudged. And there are several principles. This certainly in one figure, this was from a figure that from a review we published in JACC Cardio-Oncology. But this doesn't necessarily encompass the whole world of behavioral science and all the levers and techniques we have, but many of the common ones. And so it's arranged in the form of a pyramid. And at the bottom here, you do nothing. So you can passively monitor patient outcomes, or one step above that, provide information. And as I was saying before, I think we understand that providing information is often sufficient, or is often necessary, but not sufficient in order to change behavior. And then as you move up here, you start to get a sense of more and more effective interventions. And this isn't just in medicine, by the way, but in all domains. Medicine is actually a later adopter, I think, of principles of behavioral economics. But you start to move up here and these interventions become stronger and stronger, such as framing information. So delivering feedback in a manner that motivates behavior change. Oftentimes this can be done, as illustrated here in the figure, through peer comparisons, for example. You can ask one to commit to implementation intervention. So pre-commit to increase care management or healthy behaviors. So, and that can be done from a physician or a patient perspective, like a patient committing to monitor blood pressures, home blood pressures for a period of time. You can make the right choices easier. So make the right thing to do the easiest thing to do. And the idea there is to increase options to make the target behavior more convenient. And I think that's one of the techniques I was going to talk about today. And then finally, you can set default options and place the optimal choice along the path of least resistance, especially when many, from both the patient and provider perspective, there's many competing obligations, that making the easiest thing, the right thing to do, the easiest thing to do becomes quite important. And as a way to summarize some of these techniques. And so again, we all know that cardiac rehab is a highly evidence-based therapy, multi-component therapy, and we know it works, but nobody goes, and several factors, many factors playing into that, which I think we're all passionate about addressing. And so this figure also isn't all encompassing of those barriers, but I think the project that perhaps led Devraj and I to connect about this talk really revolved around our work in the referral space, around referral rates for cardiac rehabilitation. And so that's what I was going to talk to you primarily about today with regards to how we use nudges to increase our appropriate referral rate for cardiac rehabilitation. And then talk to you a little bit about how we're thinking about the attendance problem as well. So as perhaps at your institutions or other institutions around the country, our prior pathway, and I would even hesitate to call it that, for cardiac rehab referral was opt-in, and there was sort of sludge, so to speak, the opposite of nudging along the way. At every step, there was a barrier, starting with a clinician having to think of the need for cardiac rehab, in order before even initiating that pathway. And ultimately, this was an opt-in process. And so, as we know, the cardiologists and the care team members needed to recognize the need for the referral, needed to transmit a paper order, transmit the sign a paper order, transmit the order to a facility, find a facility for a patient. And then patients needed to find and select an appropriate cardiac rehabilitation center, and then coordinate scheduling with the center, among other tasks that ultimately needed to be completed. And so, again, this really contributes to sludge in decision making, and makes what's the right thing to do sort of the harder thing to do. So a lot of our work, or some of our work in the past in the nudge unit, had focused around more simpler defaults. So defaulting, for example, a choice in the EHR that was a checkbox or a button, one way or another. While those were certainly effective, they were sort of easier defaults to implement. Whereas in cardiac rehab referral, at least, it's a whole decision pathway that you're trying to create default option and opt out default option around. And so what we had, what our approach was, and I'm seeing some pieces of comments here, so it sounds like maybe some of the institutions in Michigan have similar approaches as well, was to start with at least automating identification and then whole care team notification of the need for a patient who is admitted for cardiac rehabilitation. And this is particularly in the ischemic heart disease space, at least to start. And so the idea here was that not only to identify the patient, but to get the whole care team together that was needed in order to refer the patient. And we also needed to restructure some of our rounding and discharge processes around this as well, particularly because, at least at the time, we didn't have the Penn as an institution didn't have its own cardiac rehab facility, so it wasn't as simple as creating a default order to be placed that could be sent somewhere, because that order really didn't have anywhere to go electronically. And many of our patients ultimately came from not only Pennsylvania, but also New Jersey and Delaware and surrounding areas as well. So part of this process had to be done in somewhat of a manual fashion. So this summarizes the process, and I think to boil it down, we created not only a dashboard, but really a workboard which patients were automatically added to based on EHR criteria, with alerts that were then sent out via secure text messaging automatically to clinical resource coordinators. And the job of, and the way we wanted to think about cardiac rehab in this space also was, it was almost like any other home-based service, and that was managed by our clinical resource coordinators, at least in the inpatient setting. And so the nudge part here, or the default option part, is that every patient was by default referred for cardiac rehabilitation. The discussion was had with the patient, and this was done independent, with the buy-in of the clinicians, but not requiring the effort to be put on their part. And all that was required in the end was that the clinician was presented with a pre-filled order, and they would have to sign it. And the rest of the work was taken care of by the clinical resource coordinator. Again, the default piece of this, though, was not only the placing an order, but also doing all the rest of the parts of the process that were needed to make this what we consider the right thing, at least the easiest thing to do. And so ultimately, this is what the work board looked like, and was intended to give all of the information needed in one place for our clinical resource coordinators to make that happen. And at the same time, a secure text message thread was generated with the care team, so everyone could be in the loop about it. If a clinician thought that for some reason a patient didn't qualify or wasn't eligible or did not want to refer, they always had the option of opting out. But if they didn't say otherwise, the patient would be referred by default. And as you can imagine, the default opt-out cardiac rehab pathway significantly increased referral rates. So I didn't mention at the beginning, but our referral rates were not so hot to start with. We were averaging the 15% of eligible patients range that has now increased to 85%, and beyond that, 85 to 90% of eligible patients referred for cardiac rehabilitation. We studied this in a difference in difference fashion using our other hospitals in our system, which didn't implement this as controls. And so I think one of the learnings here was from our perspective, at least, was in addition to the EHR parts of sort of defaulting in order, defaulting the whole pathway, we found to be an effective approach. But we know, ultimately that's only one part of the entire process, and that attendance in cardiac rehab is another point where patients drop off. And so we've been working in that space as well to think about how can we use behavioral science and behavioral economics to encourage patients, motivate patients to attend, to complete cardiac rehab, and then even beyond cardiac rehab to have sustained behavior change. And so we ran a study several years ago that wasn't a cardiac rehab study per se, but it was called the Active Reward Trial, and it was mainly trying to suss out what incentive structures could you use to create lasting behavioral change around physical activity. And ultimately, I don't present the rest of the results of that study here for the interest of time, but ultimately what we found was that in that case, at least, financial incentives that were framed in a loss frame fashion, which was in the sense that patients were given or endowed with an amount of money. It was $2 a day, so every week $14, and every day they didn't participate at their physical activity goal, money was removed from their account. So this loss framing of financial incentives, as compared to no financial incentives, was effective not only in creating behavior change with regards to when the incentives were in place, but even when they were taken away. So that was one learning actually and was encouraging to us in the sense that there's a potential for creating lasting behavior change that extends past the delivery of the incentive that we've now used in some of these studies that I'm going to tell you about in a second. So at the moment, we have 3 behavioral science-based interventions to increase cardiac rehab attendance and completion ongoing. And all of these are in various stages of completion. I just wanted to give you a sense of how we're thinking about integrating behavioral science and cardiac rehab attendance as well. There are 2 themes here. One is one question we were interested in is could we apply nudges in the context of either in-person or virtual cardiac rehabilitation to encourage patients to attend, complete cardiac rehab, and have lasting behavior change. So we're actually testing this idea of loss frame financial incentives, which it builds off that last study I mentioned, alongside a gamification intervention plus social support, which involves no financial incentive. So this idea of peer support and gamification, another behavioral science-based intervention, in order to assess whether that leads to not only cardiac rehab attendance and completion, but also physical activity in general to assess outside cardiac rehab behavior change. So that's one sort of flavor of how we're thinking about embedding behavioral science. Another flavor is actually in the area of virtual cardiac rehab. And so we've partnered with our local dominant insurer, which is Independence Blue Cross, through their clinical care innovation program to develop a cardiac rehab pilot platform with another firm called CardaHealth that deliberately embeds within it nudges based on primarily gamification principles in order to help encourage and motivate patients to complete cardiac rehabilitation. So these might be components of other virtual platforms that you've seen as well that include, I think the one difference that we're exploring is this is a synchronous live 2-way audio and video form of cardiac rehab. With remote physician, clinician, exercise physiologist oversight, modeled in some ways along the Peloton user experience. And so this is just starting up, so we'll know more in 10 months. But comparing the virtual cardiac rehab in this space to in-person cardiac rehab with embedded behavioral nudges. And so I think with that, I'll wrap up and happy to take your questions. I see a lot of comments have come through in the chat, but ultimately, hopefully, was able to convey that both medical decision making, both on parts of patient and provider, are often suboptimal, even when trying to make the right choices. And the design of choice environments, particularly the electronic ones, I think gives us the opportunity to influence behavior at scale. And oftentimes we're already being nudged within the EHR or otherwise, but often are either unaware of it, or those nudges were designed unintentionally. So strategic attention to align design with healthier behaviors is important. We think that this can also be applied to more complex decision pathways, of which we consider cardiac rehab referral one of those. And I told you just a little bit about some of our work underway to assess behavioral science-based interventions to increase cardiac rehab attendance and ultimately sort of move towards the holy grail of long-lasting behavior change. So with that, maybe I'll turn it back over to you, Devraj. Thanks again for all of your time.
Sri, that was fantastic. Really appreciate it. And you guys are doing some incredible work, not only the work that you did in improving cardiac rehab referrals, but kind of the things you highlighted at the end, gamification principles and leveraging technology such as virtual kind of synchronous real-time audio video. Maybe we could go back a little bit to your cardiac rehab referral process of kind of, like you said, making it easy to do the right thing or follow the path of least resistance. You know, in the state of Michigan, we collect a lot of various forms of data, but particularly around PCI, you know, our cardiac rehab referral rates across the state have dramatically improved over time. I think partially because of you know, the implementation of electronic health systems, be it Cerner or Epic. You know, I was curious, as you did this kind of qualitatively, obviously the numbers show that your referrals increased, but was there, were there downsides to this process that whether they were intended and foreseen or unforeseen and unintended within the system in doing this?
I think from a referral perspective, we have not noticed any apparent downsides from changing at least the framing from opt-in to opt-out. I think that because we still preserve that element of choice for the clinician, and it's an apparent, I think if there wasn't that opportunity for the clinician to interact and opt out of the choice, then you know, there may be an opportunity for perhaps inappropriate referrals. But because we still leave an element of agency for the clinician, I think this has by and large been a well-received intervention. I think as we start to move into some of the attendance projects, I think that remains to be seen, particularly some of the virtual cardiac rehab about unintended consequences and even the safety of delivering cardiac rehab that way.
No, that's great. You mentioned earlier that Penn itself, at least at the time, maybe didn't have their own center-based cardiac rehab. Has that changed? And I guess you know, many of the sites in Michigan have their own kind of center-based, and a lot of the automated referrals just go straight to their cardiac rehab, who then have to deal with the burden of filtering it out, figuring out if they're eligible, sending them to a closer site, given if they live far away. Has that process, has the kind of automated referral, has the burden changed now that you guys, sounds like you do have a center-based site?
We do have a center-based site now, but it's based in downtown Philadelphia, and oftentimes the patients, for a variety of reasons, even if you live in, it's literally like squarely in the middle of Philadelphia. So getting in and out of it is quite inconvenient. So we had explored, you know, taking this process and sort of putting that and embedding it within our own facility, and essentially making our own facility the default. And then if that facility doesn't work, then putting it sort of that work on them to be able to then re-triage the patient. But because it was actually not amenable to many of our patients, we decided to keep that process within the hospital itself, at least for the hospitalized patients. So it still happens on discharge, and so that on discharge there's a clear plan of knowing where a patient would go, rather than worrying about having to potentially re-triage them after the fact.
And
They're also a captive audience at that time. Sorry, go ahead.
of course, no, that's great. And how do you guys determine which cardiac rehab site a patient will be referred to? Is it their choice? Are they presented with a choice?
They're presented with a choice. So the patient has a choice, and we've kind of set it up the way that that in the same format as some of the other home based programs, home care or otherwise, where you need to refer a patient to a local agency, for example. So similarly, there's a directory of within our catchment area, and a patient has a choice between those, particularly the ones that are close to them, and then once that is identified, the referral is then facilitated by that clinical resource coordinator.
Fantastic. I guess my last question related to the referral, obviously referrals have increased. Have you noticed a downstream effect on enrollment and then, God forbid, participation, which is, I think, the holy grail?
Yeah, no, that's a great question. And so I'll admit that those are data that we don't have. We've, I can say informally from talking to, because we do reach out to all of these patients, of course, after discharge, it's so informal, I hesitate to even say it. But I think that what we had wanted to do was potentially partner with our insurer to assess claims around cardiac rehab attendance. I think what we've opted to do since then is start to work on some of these other projects, including the virtual-based cardiac rehab option, because I think there we can very sort of at a very granular level measure the degree of engagement a patient has, not only with each session, but even what they're doing in each individual session and even between sessions. So that's a long way of saying no, we don't have the data around attendance with regards to these referred patients, at least in any rigorous way.
Sure, no, that's fantastic. I guess I'll continue to hog the microphone. Anyone feel free to chime in with any questions. In terms of virtual cardiac rehab, obviously virtual care in general has taken a center stage over the last 18 months with COVID. I guess, are there methods that you guys are exploring to incentivize through nudges or gamification or behavioral economic theory, incentives to incentivize patients kind of down the traditional pathway that's been, much more established over the last 30 years, as the virtual or hybrid kind of cardiac rehab takes hold, and I think everyone, at least somewhat, is waiting with bated breath on whether Medicare is going to continue paying for it. And I know we had a great talk by Karen Louie a couple months ago about this.
Yeah, no, great point. And so that the study that I mentioned that we're calling Impact CR, it was actually completely. It was originally designed pre-COVID completely around in-person rehab. So with the idea that although the intervention with the virtual intervention now, we've embedded the nudges within the cardiac rehab within cardiac rehab itself. Impact CR is designed to study outside of cardiac, like where can we embed nudges outside of the cardiac rehab session itself. So whether that's one arm with financial incentives or another with gamification plus social support, and that sort of combination of the two. The reason why we chose those is because those have been found to be effective in other studies we've done with just physical activity in general. And so it's basically that same frame. It's a game that involves a number of points, and you can go up and down levels based on points. And then you have a patient-selected social support person who's also there as another nudge that we've seen work in other spaces. So now that's why we want to test that with attending cardiac rehab as well.
And do you mind? I don't know if you're kind of at liberty to elaborate a little further on maybe kind of how the degree of financial incentive is informed. Obviously, many patients face financial barriers, not only transportation to cardiac rehab, but paying their copays. I guess how is that level of incentive determined? And is the outcome metric participation in center-based cardiac rehab or physical activity at home, like it would be for virtual cardiac rehab?
So with regards to the financial incentive determination, so that was not determined necessarily with cardiac rehab copays in mind, or with designing around any individual's copay. But that's a good question. So the copays continue as they otherwise would in the real world. And the other part of your question around and by the way, the financial incentive design there is the loss framed approach. So where someone gets same thing from Active Reward, the $14, and then they get the money is removed every day they don't meet their physical activity target, and the primary outcome is actually the physical activity.
Okay.
And the secondary outcomes are the attendance and the completion of cardiac rehab, is the way that study is designed.
Got it. No, that's great. We have a question here from Mike Thompson from MVC, also one of our partners in improving cardiac rehab. His question was, did automatic referral have improvements in enrollment equitably across patient racial socioeconomic status, obviously alluding to healthcare disparities in cardiac rehab? I know you can't really track enrollment, as you noted before, but in kind of your work, have you noticed these nudges or behavioral therapies kind of differentially affect patients by race or gender or socioeconomic status?
So that's a great question, and that's exactly as you might imagine what we're exploring right now. We just wrapped up a statin prescription nudge study, which was explicitly designed to assess that. I wouldn't say that we had originally approached this the study that I presented with whether explicitly that particular nudge would increase cardiac referral rates equitably. But that's a primary focus, I think, of all of our work, including that virtual cardiac rehab study I had mentioned going forward. So I think that the jury is still out but is a primary objective that we increase rates of adoption of any guideline-directed therapy with a nudge equitably.
Fantastic. Sri, thank you so much for joining us.